excellent introduction to start off, Dr. Poulos. My name is Claire. I am a white, brown eye, red hair, white woman using American Sign Language. And I'm pleased to introduce our amazing two presenters this morning, Dr. Sarah Victor and Adam Schmidt. Both are clinical psychologists and researchers at Texas Tech University, and conducts research on biological and neuropsychological mechanisms connecting adverse childhood experiences to risk and resilience within vulnerable populations. Dr. Victor and Schmidt will share their own lived experiences of disability involved in research and advocacy. And they will specifically describe how their experiences have shaped their work and learning in support and advocacy for disability trainees, and recommendations for improved access of graduate training in psychology and other related fields. At the end of this discussion, we'll have time for some questions from the audience. We thank you both so much for being here, and I'll turn it over to you guys.
Thank you so much for having us. Really just excited to be here. So our goal for today was really to try to keep this in a kind of a more informal discussion. So we have some topics outlined here on the slide, and Dr. Schmidt and I will alternate kind of going over some questions that we'll each attempt to answer, and then we'll leave time at the end for additional questions from our moderator and from the audience, from folks watching on the live stream. But we won't have a lot of content on the slides. This is just kind of to orient folks to where we'll be going. But I thought it would be great to just start out with introductions, talking about our academic backgrounds, our experiences with disability, and how disability shows up in relation to our scholarly work. So since I'm starting with the question topic here, I'll have Dr. Schmidt start with his intro and we'll go from there.
Hi, thank you. Yeah, thank you for having us. We're really excited to be here, and thank you for allowing me the opportunity to be a part of this, great conference. So my name is Adam Schmidt. My background is actually in pediatric neuropsychology. I do research on the role of kind of childhood experiences and risk and resilience within different populations. I do a lot of work with youth involved in the juvenile justice system and trying to understand their kind of psychological and cognitive development. I have congenital glaucoma and have been blind, or not totally blind, but visually impaired since birth. And so I have a lot of lived experiences kind of throughout my educational journey. And actually, interestingly enough, because of my work, I'm probably one of the few people in the country who's actually experienced kind of education, both as being involved in special education, as being a care provider, kind of working within that system, doing my clinical training and research. And also now I have a son who is also visually impaired. So now I'm a parent. So I've got different perspectives on training and education because of my lived experiences. I also have a unique interest in kind of training in general, including training with individuals with disabilities. So I'll turn it back over to Dr. Victor. I'm excited to be here. Thanks for having us.
Thanks so much. So I am also a PhD in clinical psychology. My research, most of my research focuses on risk and protective factors for self-injury and suicide, using ecological momentary assessment and other methods to understand changes in risk in daily life. I grew up with a father who was disabled, ultimately with multiple disabilities, and that experience got me interested in disability activism and disability rights. And it wasn't until a little bit later in life that I started to recognize that my own experiences with recurrent chronic depression and generalized anxiety disorder were also falling under the umbrella of something that I would identify as a disability. So as a faculty member, I've started to expand my scholarship looking at experiences of mental illness among psychology faculty and trainees, some of whom would consider that a disability, others might not. So issues around disclosure, access, accommodations, and how those experiences do or do not overlap with research interests. And I'm just really excited to be here. And I'll turn it over to Adam for the next topic.
Yeah, so I think we kind of structured this as a kind of a discussion, kind of a free-flowing discussion between Sarah and I. So the first thing kind of we wanted to touch on is barriers, and kind of I think we each have our own experiences and our own thoughts about this. But the way I think about barriers to what are potential barriers to trainees and providers in mental health, broadly speaking, mental health with disabilities. And I was thinking about this to kind of try and organize my thoughts. And I think I see sort of two separate maybe categories of barriers. One is kind of just what we could call physical barriers or logistical barriers. So those are real practical things. So from my own experience, it would be like access to software packages that maybe are not accessible for my screen reading software, ability to read paper notes. So just, actual things that the disability makes it more challenging or kind of needs to be accommodated. I think the other type of barriers, and these are a little harder to kind of consider, is more barriers and expectations. Sort of, again, speaking from my own personal experiences, there are certain things that I do and I can do just fine, but I don't use vision. And there's a barrier between people, sometimes, not often, but sometimes there can be a barrier with individuals not knowing how I can do something because they use vision and that's how I do something. So how is it possible for you to do the same thing without vision? I don't know if that makes any sense, but those are kind of, I would say, logistical barriers and then barriers of expectation. I think they're both very real types of barriers. The expectation barriers are a little bit harder to kind of categorize because they're different. Different people have different expectations, different biases coming into things. I remember once in college, I was taking a research methods class. It doesn't seem like there should be barriers with the research methods class, but I was told by the faculty member, and this was at a prominent R1 school, a large school, I don't think you can really do things in this class. I'm not sure how you're going to make it through this class. And we worked it out. It was fine. He ended up sort of figuring out ways to the things that supposedly were barriers really weren't barriers, but they were just kind of part of that initial barrier of expectation, for lack of a better word. I've faced barriers because my interest is in psychological assessment. And these are kind of what, when we do psychological assessments, sometimes it's just questions, but a lot of times it's specific tasks that people have to do, like an IQ test or a memory test or something like that. And some of those things I can do, some of them I can't, because in order for me to do them, we'd have to completely change the nature of the assessment, the nature of the test, and that's not practical because it is not how the test is designed. So I had to find ways of working with other students and other trainees or other providers to get the information. And there were sometimes barriers regarding that, both those logistical barriers, but also, well, how are you going to do this? You can't get the information, that you can't do these tests. And again, it just requires kind of working through those and trying to figure out, and we'll get into this a little bit later, I think, with mentorship, like what is realistic, what's not realistic. So those are examples of barriers that I think you can face. And they're, I think, both really real, and they're both, I think things that can be adjusted too, but there's things to be aware of and kind of think through both of those levels. And I think especially the barrier regarding expectations has a lot of implications when we talk about later about disclosure, accommodations, mentorship, and that kind of thing. And I think Sarah will get into this, but I think another very real barrier is the barrier of maybe not seeing something as a disability when it is. And I'm in a position to where I think most people would see, visual impairment or blindness as a very real disability. But I think there are other disabilities that are in fact disabilities, but people don't always see them that way. And I think that's another very real barrier. I don't know, Sarah, if it's a good jumping off point for you, if you want to.
Yeah, sure. So, I think a lot of the things that you were just talking about were also on my mind, as well as kind of attitudinal barriers around even thinking about access and disability, before folks kind of thinking about barriers to entering the field, just thinking creatively about things like our admission system portals and, our online information about how to apply. And, lots of folks who either don't have disabilities or haven't been around folks with disabilities don't always just think through, how do we find out if this is accessible to a screen reader? How do we find out, how to add alt text, things like that. And that was something certainly in terms of physical accessibility, our family addressed a lot growing up. My dad had significant mobility impairments and was ultimately in a scooter by the time I was in graduate school. And there were a number of times that we would call a place and they would say, oh, we're wheelchair accessible, except the bathroom or except the, this half of the building. And I was like, well, I don't know that I really want to go to a place where my dad can't access the bathroom, things like that. And then I also think a lot about these internalized barriers around, identifying as disabled, thinking through what disability means, thinking about what kinds of accessibility or accommodations might even be appropriate. I think one of my challenges was, given the way that academic research is set up, a lot of the accommodations that you might see as an instructor for students getting requests for accommodations don't always make as much sense for things like psychiatric disabilities, time and a half on an exam or, a different modality of displaying the material. And so one of the barriers for me was, well, if I don't know what accommodations I might need, or I don't feel like there's an accommodation I can request, then maybe I'm not disabled, or maybe this isn't a disability, even though we realize that those things may not go together. So I think about those. And then one barrier that kind of leads into the next topic is just lack of visible mentors in the field, or, people that are open about disabilities or who have disabilities. And that I think kind of transitions the next topic is, why does this matter? My notes to myself are, I'm guessing folks at this set of conference presentations probably buy the idea that this is important. But, I thought it might be helpful to think about sort of the importance of mentorship and training and disability access. And one of the things that I think is really important is this aspect of perception and awareness that folks with disabilities exist in the field. And if you can see mentors or faculty or instructors or psychologists in the community who have disabilities, then that can convey to others with disabilities, hey, this is a possible field I could go into. So that was one of the things I was thinking about in terms of why it matters to have a pipeline supporting folks with disabilities in this field. And of course, we know that there's lots and lots of people with disabilities in our communities that we're serving, as clients or as patients. So I think it improves probably support and access for those individuals as well. Those are kind of my points there. So I'll transition to Adam for the rest of that.
Yeah, I think so. I think those are really good. So I'm going to jump back to one thing you said about, you were talking about kind of access points, like with the application portal and just real,
Mhm.
one thing that I think is interesting is there's a lot kind of as you go up. So for example, Blackboard is a really common course software that's used a lot of places for undergrad, graduate school. It's very accessible as a student. It's not very accessible from the design and the instructor. And so there's a lot of different things. If you can have a software package or have a particular thing that might be accessible at one point of entry, so for like the person inputting the data or the person applying, but then on the back end, it may or may not be accessible. It really just depends. And so that's something that I actually have come to realize along the way, that like these things are not always universally accessible because they have different aspects of it. So that's just something to kind of keep in mind. Yeah, it might be accessible for a student, but if you're an instructor, like say you're a resident or a postdoc, and you have a different set of duties and privileges, that same suite of things may not actually be accessible at what you need to do at that point. So I wanted to kind of throw that in. It's a different, just a, in the way that some of these things are designed. I also think, though, why is it important? I think disability is part of diversity, equity, inclusion efforts, and it's often, I think, unintentionally not talked about or not referenced in the same way in those discussions. I've completed many kind of forums, demographic forums that kind of look at different demographics or look at diversity, and disability is nowhere mentioned. So I think it's important that I think you have several things with disability that make it a little bit different, because you have the kind of social aspects and the different biases that play a role. But then again, you have these actual very real logistical things that also complicate access and inclusion efforts. So I think it's important to have it as part of that broader discussion, because it's often, I think, less so. It's getting less and less. It's becoming more and more integrated into that discussion. But that's a fairly recent development. I don't know what you think about that, Sarah, but that's been my experience, is that it's often left out of this discussions.
Yes, I find it's often not included or considered kind of separate or different.
Mhm.
And I think that plays out in terms of disclosure decisions. And I think about, for instance, when folks are applying for faculty positions or other positions, and you have to write a diversity statement.
Mhm.
And there may be different implications about including information about a disability in your diversity statement compared to other aspects of identity. Now, that's not to say that there might not be concerns about disclosure of other aspects of identity too. And certainly that idea of mental health professionals in different roles, and how in some contexts that role has more accessibility or more considerations than in others. I think, for instance, about our graduate trainees, who are students in classes. They are sometimes instructors of classes. They are researchers. They are employees of the university. And so if they need accommodations, where they go for those accommodations is very different, right? You can have a student that says, I need accommodations in Blackboard for this graduate course I'm in, and I also need accommodations for the undergraduate course I'm teaching. And those go through totally different offices, totally different systems, totally different sets of resources. So really interesting, important point there. And what that you were kind of mentioning about the fact that just because a system is quote unquote accessible doesn't mean it's accessible for everyone.
And in all aspects, I think. And you mentioned kind of mentors and examples, and I think that's super important, not only for other people with disabilities, but I actually think for the clients that we see and the patients that we see in mental health. I think it's a powerful example. Like one of the things, we're talking about barriers. One of the barriers I haven't personally experienced really very much is a barrier of kind of patient confidence or client openness. That's almost never happened to me in the time that I was in training or seeing patients. I think my supervisors were worried about that. They're always worried that clients would be like, oh, well, this guy can't, help me, or they can't treat me. That almost never happened. I can't actually think of a time that happened. I'm sure it maybe happened once or twice, subtly. But I think that's another powerful example of showing, when you're treating someone that's struggling with a disability, be it whatever that is, having someone in that position that maybe it's not the same disability, but just seeing that is another powerful example to those, I think, to the community we're serving. At least that's been my experience. I was worried about that kind of going in clinical training, that I wouldn't be taken seriously or people wouldn't think that I was competent. And that really, to my delight, for lack of a better word, hasn't been something I faced as much as I thought I would.
Yeah, and that's certainly something that I've thought a lot about, because I'm in a position where I have kind of decisions about whether or not I disclose my experiences or not. And when I was in training, that didn't come up with my clients. But I often thought about it, and I had clients that would ask, well, what do you, especially, teen clients who would say, well, what do you know about this? And, the question of disclosure and how that fits in with your theoretical orientation for therapy. But now that I'm more kind of publicly open about it, if I were to start seeing clients, if you Google me, if you look at my Twitter, it's out there. And one of the areas that we're interested in doing more research on is, to what extent do clients or patients want mental health providers who have experience with psychiatric disabilities? To what extent do they not? Does it matter whether there's a match between what the client's struggling with and what the provider's struggling with? So that's, I think, a really interesting open question, but I haven't had a situation where anyone's kind of yelled at me about it or been, concerned about my training there. I wonder if it makes sense for us to kind of, I know on our bullet points, we've got accommodations next, but I wonder if maybe disclosure makes more sense, and then we can
I think we should
go back.
I was thinking the same thing.
Yeah. Let me look at my notes. So we were kind of talking about, decisions around disclosure, non-disclosure, factors to consider, situations where it felt more or less feasible, disclosing even when I think the most common situation where folks are disclosing is when you're requesting an accommodation, but that isn't necessarily the only context where disclosure comes up. So I'd love to hear your thoughts about that, because I know when we first started talking about it, you and I have very different experiences of disclosure. And
I think it does depend on these visible versus invisible disabilities. I mean, any disclosure that I'm going to not do goes away when someone meets me for the first time. I use a guide dog for navigation, so it's relatively obvious. But I think there is at a point when I'm applying, do I disclose? Do I disclose intentionally? Do I tell my letter writers not to say anything? Do I tell them to say anything? And there are all those different decision points along the way for, I think, both visible and invisible disabilities. And I think they both have different disclosure, they're different processes. They're, similar kind of, they're both disabilities, but it's, I think you can think about them a little bit differently and how that process unfolds. So for me, and this is for me, so first of all, I think that there's no right or wrong answer to this. I don't think it's like, oh, you always should disclose when you're applying, or you should never disclose when you're applying. I actually I don't think my experience would suggest that just talking to people, there's no right way. There's no one right way. And it can change in the situation. What I eventually sort of settled on is I would disclose, but disclose in the context of my materials. So for example, when I would have to write a teaching statement for faculty jobs, I would talk about my experiences, as someone who's visually impaired in higher education and that worked for me. That was just the way that I decided to do it and how I felt comfortable doing it. But for example, when I applied to clinical jobs, I wouldn't specifically disclose. I wouldn't ask my letter writers to not disclose. And so it was kind of a toss-up whether they figured it out from looking at my materials, because there are things on my Vita that if you kind of are actually looking at it thoughtfully, you could probably say, I wonder. but so it's kind of different depending on the clinical jobs versus more academic jobs. And it wasn't so much that I was specifically not disclosing for those clinical jobs, but I do think that it was just maybe not the opportunity. But I do think, at least in one situation that I can think of, I'm pretty sure they didn't specifically know that I had a disability. I walked in, the interview went really well. I was told by the chair of the department, "Oh, yeah, I think you're great. You're going to be hearing from us really soon. We really appreciated meeting you." And then all of a sudden, I didn't get the job, didn't get an offer. And I think it was honestly regarding billing, that they couldn't figure out how to bill for my services if I was using someone else to do my testing. Anyways, I could be totally wrong on that. I could be totally wrong, but I had that experience at least one time, and it was kind of interesting. Saying, huh, okay, maybe I should have disclosed up front. And anyways, but a lot of times I just sort of, what worked for me, what felt right for me, was trying to not conceal my identity, but also not, not broadcasting it specifically to do it in the context of the other materials I was submitting. So I wasn't concealing anything, but I also wasn't drawing attention to it, because I felt like I needed to draw attention to my ability to do the job, or to be a good postdoc, or to be a good graduate student. I don't know if that makes any sense. And again, I don't think there's any maybe specific right way, because I think it's different depending on your disability, depending on your level of need of accommodations, and depending on what kind of position, or who you're talking to, what you're talking about. In a sense, I think my situation is a little easier, because it will be disclosed. You meet me and it'll be pretty obvious really quickly. Oh, this individual can't really see very well, or it's probably visually impaired. So I don't know. That's been my own kind of disclosure journey. I think when I was even in college, I didn't want it to come up at all. Like I was I'm not, I'm doing this I'm not telling anybody about this. I don't think that was a really good decision at the time. I think I probably caused myself a lot more pain and angst, and honestly, to some extent, it wasn't fair to other people. That's not always a consideration, but it's something I think about. Like with me, like, well, I'm going to need transport if I go to a new place for a job interview or whatever. I'm not going to be like renting a car. So I think my thinking over this has changed over the years, and it'll probably change again as I go through the field. But that's been my kind of disclosure journey and experience. I don't know what your thoughts are, Sarah.
Yeah, no, I think also it's been, certainly something that has changed for me over time, and varies a lot by context and by situation. I think some of the most common questions I get from folks are around disclosure. And I really try to emphasize again, like, you don't owe anybody a disclosure, this is your life and your experiences. And also, there are risks and benefits to being more or less kind of open, especially with disabilities that are to a large extent concealable. One thing that you touched on, Adam, I think is really something that I consider a lot with disclosure, which is this uncertainty. Once you share that information, you don't have any control over how the person responds. You don't have any control over whether or not they tell anybody else. You can ask them to do so or not do so. And sometimes you don't know how it's changing how you're being evaluated, right? You don't get the job, or you don't get the grant, or you don't get the award. And it could be for some totally unrelated reason, or it could be because of something disability related. And that uncertainty sucks. Or I'm in a situation where I've written scholarly work that's involved disclosure, and I have had a lot of people respond to that very positively. And I've also had a lot of folks where I know they know about the work, I know they've seen it, and they have not said anything. And then you're sitting with that, like, are they uncomfortable? They don't know what to say. Do they think it was inappropriate and that's why they're not saying anything? So I think that's something that I often encourage folks to think about when they're making those decisions is like, what's the goal for you of disclosure? What are the potential costs and benefits? And how would you feel if, you know, kind of these different outcomes occur? So for mental illness disclosure, psychiatric disability disclosure, often it comes up when I'm talking to folks applying to graduate school. They want to know, do I put that in my personal statement? And usually I give them the advice, you know, the general advice is no. It's really hard to know if that's because people will judge you or because people are afraid someone will judge you, or both. And I sort of tell folks to think about it like, you know, which situation would you rather be in, where you get an offer of admission and it turns out that they're not really going to be supportive of your needs around this experience, but you don't know that because you didn't tell them. Or you do disclose and you don't get an offer of admission because there's maybe stigma there, or, you know, that flags some concerns. And I've had some folks say, I don't want to be at a place that doesn't kind of acknowledge my full experience. So I'd rather disclose and have them know upfront. And I've had other folks say, I want to get into grad school. I'll deal with it. You know, if they're not supportive, I'll deal with that down the road.
Yeah, and I think that's a good, I think that's a really good point, because I do think, I think part of it is, like I said, there's no right way of going about it. And I mean, I kind of tend to fall into I don't know, I feel like my thinking has changed. Like I said, initially, you know, it sounds like your thinking has evolved too, but I think initially when I was a lot younger, well, I just wanted to get in. Like, right, it wasn't even really an issue for me. And now I'm kind of more like, you know, I don't know if I want to be at a place where it's like I say something and they're like, oh, we can't deal with that. I'm not sure that that's a great fit for me. So I think your thinking kind of change on that. And I mean, I think with mental illness and even like things like learning disability, I do think there's still a stigma in the field.
Oh yeah.
And I don't even know, I don't know what to do with that, because it seems counterproductive in a lot of ways. And I definitely, the situation, and I have to be guilty of this, I've counseled students not to disclose things in their personal statements. Because I do think there's a stigma, and that's not fair.
Yeah, I mean, our data, we did a very large study of psychology faculty and trainees, and we found that there was certainly a stigma against what's sometimes described as me search, or research that is related to some aspect of your experience, particularly if it's related to mental illness. There's also data from larger studies showing that like mental health professionals actually sometimes report higher perceived stigma for mental illness than people in the community. And one of the reasons for that is that mental health professionals see folks when they're struggling more, and they're more likely to see folks who are you know, quote unquote, treatment resistant, because those folks come to treatment with more providers for longer, right? So this is especially true if you work in a hospital setting, if you work in a high acuity setting, you're going to see people when they are really struggling. And so the folks who have an episode of depression and recover and stay well, like psychologists rarely see them. And so mental health professionals are often more likely to have kind of more pessimistic prognoses for someone if we don't know about their course of illness, just because of what work we do.
Yeah, that makes a lot of sense.
I know we only have 4 minutes before we go to the general Q&A, but we will have time for the general Q&A. So what do you think we should spend the last 4 minutes on? Recruitment, mentoring?
I think just briefly.
Accommodations,
Accommodations, just really briefly. You know, that's a hard one, because different people need different things. And I'm on a member of a academics listserv for individuals who are faculty and who are blind or visually impaired. And everybody does things in a slightly different way. So there's no one, like, you can't assume that accommodations are going to be the same. I think it's important to be just receptive to accommodations, and even asking a person when you're trying to recruit or work or train a person, what do you think you need? And try and work with them. People have generally pretty good ideas, but also sometimes they need to know I think it's helpful for individuals mentoring and working with individuals with disabilities, saying to kind of be part of that process. Like, here's something I wonder about. Do you think you would need accommodations for this? And trying to be more active and engaged. Um, to me, that's really helpful, because there's a lot when I'm starting a new position or a new job, or learning something new, I might not know what I need to be accommodated. So I think it should be a conversation and just kind of ongoing, and really, I think it helps to be forthright in knowing that someone might need accommodations going in, rather than putting them on the spot to ask for it. Does that make sense? That's just my experience.
Yes. Yeah, and I think that actually fits with some of the points I wanted to make around the mentoring aspect, right? Is that not everybody necessarily knows what accommodations are possible, or what areas might require them versus not. And that's also something I was reflecting recently that I thought my mentor did really well when I started disclosing to him as a graduate student, because I was coming from the perspective of, I'm really struggling. I don't think I can hack it in academia. This is not going to work. And he took my concerns seriously. But rather than sort of saying, well, you need to go to disability services, or, well, if you don't think it's going to work, then I guess it's not going to work. He was really thoughtful about, well, what things are a struggle, what might be some aspects of an academic career that actually are more flexible for someone with a psychiatric disability compared to a traditional 9-to-5. And I think having those conversations from a perspective of just genuine curiosity and support, rather than trying to kind of tell me what to do, or assume that if I said it wasn't going to work, that was necessarily the case, I think was really important, and something that I try to reflect when working with students.
Yeah, I totally agree. And just as a quick side point, you mentioned earlier the difference between students and maybe faculty. And I think that's a really important difference, because students, I think the field and institutions of higher education do a fairly good job of accommodating student needs with disability. I think it falls off significantly when you get to the non-student level, even to the graduate student level. It's okay. It's not necessarily great, but then to the faculty level, those accommodations, and especially like for me, there's pretty modestly priced, but there's technology that I need. That all has to come out of the department. The university has no centralized fund or no centralized approach for paying for those kind of accommodations or work modifications, which I think is kind of interesting. And that's not unique to our university. That's just how it is everywhere.
Yep. When I was on postdoc, I had a back injury that was temporarily disabling, and all I required was an ergonomic chair, and it took about 6 months, and I was told that it was going to have to come out of my supervisor's institutional funds. And this is a chair that's maybe $200, so it wasn't a huge deal for her. But you could imagine if a faculty member was recruiting someone with a visible disability that would have potentially higher costs around physical building access, software. That's, even if the person wants to not consider that, we know human nature is such that people are going to think about those things. So
absolutely
gets to those structural issues. But I know we're 1 minute after the hour, so I want to make sure that we leave time for audience Q&A with our amazing moderator. I haven't been looking at the chat.
Both so much for your incredible, insightful discussions. It really is something that I think a lot of people with disabilities who want to go into the medical field and healthcare fields will find very valuable. We have a list of wonderful questions from the audience. One person has asked, how do you guys get through school, particularly with navigating accommodations? And I'm curious, what is your advice for aspiring or new trainees with a disability to get through grad school and in internalizing those barriers so that those expectations that they have, they can face them and they can get exactly what they need? Maybe a community of other trainees. What are your thoughts?
Oh, I have, yeah, sorry, Adam, go ahead.
Go ahead. No, go ahead, Sarah. And yeah, because I think we'll have complementary.
Yeah, I think it's valuable to, as much as possible, try to find a program and a mentor who is likely to be supportive, and to the extent that you can find that out when you are applying or interviewing. Does the person talk about diversity, equity, inclusion, accessibility in their materials to prospective students? Does the program? What resources are you able to find available? And then having a conversation with the people who are supporting you about what you've already identified as accessibility needs, as well as what you've identified as challenges that maybe you're not sure if there is something or what that would look like. And sometimes for psychiatric disabilities, that isn't necessarily something folks feel comfortable disclosing broadly, but trying to at least find someone within your training program, whether it's the training director or your faculty mentor, or if you're an undergraduate student, a faculty member who seems supportive, just to kind of have that person help you connect with resources at the institution.
Yeah. I think too, part of that is don't get discouraged, because some people just won't be supportive. It's not necessarily that they're, it's not that they're terrible people, but they just don't know, and maybe don't have the time or don't feel adequately up to the task. Don't kind of keep going, right? I think that's part of my thing is I was fortunate. My graduate advisor had like a blind roommate in college, and so he was like, oh yeah, okay, they can, he'll be fine. That's literally how I got into grad school, I think, is that he was sort of open and he was familiar enough with my disability to not be anxious about it or not be concerned about it. And so I think that's, I think really important is just keep trying. You're going to find someone who's going to be supportive. It might be the first or second person you come to kind of ask for guidance or, kind of feedback, but you're going to find that person. Just keep going, and know that sometimes people aren't even aware of the biases that they have, and have a little grace for that and a little patience. The other thing I think is important really is just to be realistic about what you may or may not be able to do. You can do a lot of things, but I think part of mentoring is also like listening. And I don't know that I would have gone into neuropsychology had someone not taken me down and sat down with me when I was in grad school and said, hey, here are maybe is a better option for your skill set. And that's one of the reasons I'm in academics, because I think it's a better match for my skill set than being in practice somewhere. So I think that's also really hopeful is for trainees to be kind of self-reflective and know what is possible. There's a lot that's possible. I'm not trying to dissuade anybody or say you can't do certain things, but you need to be realistic about your own abilities and skills and where they best are matched for.
Yes, thank you so much. It really sounds like the visibility of professors and people in the field with different disabilities is so powerful, and it opens up a lot of avenues for new trainees coming into the field. And even Dr. Victor, you've disclosed about your own experiences, and I'm sure it's so powerful. It has such a powerful impact on opportunities and changing the field going forward. Some questions have come up from the audience, more in terms of what accommodations in higher education or policies do you feel would be necessary for mental health professionals with psychiatric disabilities that are not just medical leave or withdraw?
That's a great question. I actually think that because many psychiatric disabilities are episodic or fluctuate over time, a lot of the accommodations that I think about are things like modified timelines, the ability to take leaves that is really challenging as a faculty member. Both Adam and I have navigated this with parental leave. You know, you might not teach a class, but your grants don't stop, your students still need mentoring. So I think to the extent that programs kind of institutionally can create additional supports for those kinds of responsibilities when people need to slow down or take a leave of some kind. So it's sort of related to the access of leave, but more institutional, like having a secondary mentor identified to support students. I think it's also going to vary a lot by individual. So for instance, one thing I've considered is requests around the timing of classes during the day. You know, if people have sleep difficulties that make it easier for them to teach early in the morning or easier to teach in the afternoon, that's something that you could certainly think about. Those are kind of the main things that I've thought about related to those types of accommodations. But it is really tricky because it's not, you know, there's not a piece of technology or a specific, you know, physical or kind of technological solution.
Yeah, I think part of what just, and I don't have the same experience, but I agree flexibility is key. But I also think openness to kind of having those conversations, kind of getting back to the idea of stigma, and people are so like, I don't know if we can talk about this and you know, or if I should talk about this, or just I think that my thought, and it's just a thought because I don't have the same lived experience, is that even openness to conversation would also be really important. I don't know what to think about that. So, but.
Yeah, I think certainly one of the things that I've experienced since disclosing more is that more people come to me now to have those conversations, which is both amazing to serve as that resource and support, and also is an example of ways in which faculty who hold underrepresented identities or experiences sometimes get additional like service mentoring burdens. We know, for instance, that racially minoritized faculty are more likely to get students from minoritized backgrounds to come to them for support. So I think that that's really valuable. The other thing I was going to say, both for faculty and students, is thinking about access to medical care or psychiatric care, especially in mental health settings. Mm-hmm. So, for instance, when I moved to Lubbock, I needed to find a provider, and the person I found, who was really well regarded, not a faculty member in our department, Chuck Giles, if you knew him before he moved, Adam, started seeing him, was great. We didn't really click, so I found someone else. But later I learned that he had like a weekly poker game with a number of faculty in our department and our program. And obviously I didn't expect he was going to say anything about me as a patient, but an example of these dual relationships and overlap if you're in a field where you also need services.
Yeah, it's a good, really good point.
Wonderful. Yes, it's definitely tricky to navigate through those rules, and oftentimes you can't avoid it. I'm curious, Dr. Schmidt, you spoke about sometimes supervisors or advisors being concerned about a person with disabilities and how it will impact patient care or how the patient will feel working with providers with disabilities. What is your advice for navigating those conversations with superiors who may be concerned about a person with disabilities providing patient care? And how would you suggest individuals navigate that in a way that advocates for themselves while simultaneously not burning bridges?
I think that's a great question. I think part of it is, you know, just being forthright and kind of admitting what you don't know and saying, yeah, you know, if a supervisor says, well, I'm concerned about your ability to do this. So first of all, being willing to talk about the strategies you've developed to where that's not a problem, you know, or saying, well, actually, here's how I handle that situation. And I would do this, this, and this. That can provide a lot of peace of mind for supervisors and kind of, you know, training supervisors to understand the process and to understand how you do things. And part of that is having them watch you, do whatever that might be of a concern. And then also being open to feedback being open to feedback from your supervisors about, well, tell me when I can do a better job. And let's try to have that open conversation about how to better, serve the patient, serve the client. So that's not a concern. I think that's really important, to being open to feedback and then open to keeping the conversation open.
Yes, absolutely. Open conversation. And I can also see as well how trainees with disabilities may feel that extra load of needing to prove
Yep.
themselves to supervisors and to prove that they can do it. And they don't have the same benefit of giving that benefit of the doubt, right? So, as those individuals who do not have a disability.
I think also being creative, because sometimes supervisors are going to say things that you're like, oh yeah, that is, I didn't think about that. And just being kind of open to hearing that feedback and kind of being willing to work creatively with the supervisor to try and think of solutions. Again, I think most supervisors are going to be supportive in principle, even if they're skeptical. They're going to say like, well, let's see what we can do. Yeah, you're going to run into the occasional person who's not going to be that way. But I think giving supervisors the benefit of the doubt, I think that's helpful. So.
Yeah, I've certainly had a number of folks, as I've discussed these issues, bring up, well, what if someone is an impaired professional? What if someone's mental health condition is causing them to be an ineffective clinician? And my response is, that is obviously something we should care about for all of our clinicians, right? But the truth is that the research, there isn't any research to suggest that people who start grad school with a history of a psychiatric disability are any more likely to be impaired as a professional than people without. You could certainly develop some kind of impairing either mental health or substance use or other kind of condition at any point. So rather than trying to select out for people with these histories because you're concerned about some risk in the future, I think it's better to try to train all of our mental health providers to identify impairment in themselves, to know what that looks like, to know how to address it, rather than to say, well, if we just don't admit anybody who has this history, then we've solved our problem of impaired professionals, right?
Exactly.
Yeah.
Yes, and I think that's really powerful point that you just brought up. Thank you both so much for sharing your stories, your experiences. It is really invaluable for everyone. And I'm going to go ahead and turn it back over to Dr. Poulos.
Thank you.
Thank you.
Thank you.